continuing on in our critical care symposium, it's really a pleasure to introduce Dr. Joshua King. He is an assistant professor in the Department of Medicine along with pharmacy and is one of actually just 3 nephrology medical toxicologists across the world. So we are lucky to have him here with us at the University of Maryland. He is also the medical director of the Maryland Poison Center, as well as the program director for our nephrology fellowship here at the University of Maryland, and also sits on the board of directors for the American College of Medical Toxicology. Poison patients, the crashing or critically ill poison patient, can sometimes be one of our most challenging patients that we take care of, the sickest patients that we take care of. And well, for some select critical illnesses, critically poisoned patients, there are new guidelines. There are updates to guidelines. And so I'm very much looking forward to hearing Dr. King. So, Dr. King?
All right. Thanks so much, Dr. Winters, for the great introduction. It's always hard to follow Dr. Chan. He's dapper. He's intelligent. He, has really cool looking slides. I've got walls of text and bad memes. But we are going to talk about, several different issues in poisoning. And these I chose because they all have either updates or new approaches within the past several years. In terms of disclosures, I do want to mention, these are all actual cases from University of Maryland Medical Center. They have been modified, so hopefully you can't tell who they were, or if the patient should be watching for any reason, they shouldn't be able to easily identify themselves. I am talking about some of the extra systematic reviews and guidelines, and I do belong to that work group. And basically everything for poisoning is not FDA approved, except for N-acetylcysteine, and we'll be talking about non-FDA approved protocols for N-acetylcysteine. So that's the way it goes. So let's start off with a 50-year-old patient who presents to the shock trauma hospital. She presented to the TRU, the trauma resuscitation unit, after falling down a flight of stairs, was confused, put in a C-collar, had shock presumed due to sepsis, UTI, maybe that fall, had a substantial lactic acidosis noted in the ED, but when she came to the ICU, it had mysteriously vanished. Maybe it was just really good care, but what didn't go away was her progressively worsening anion gap acidosis. And 6 hours later, she had even worse metabolic acidosis with acute kidney injury, and most excitingly, of course, a urinalysis that showed some hematuria and pyuria. But then what do you do with that? Well, we contacted the nephrology team. We were called over at the Poison Center and said, this sounds like somebody we should go see. And we all went together into what you do, the urine room. And we looked at said urine and we saw, oh, these are exciting, right? These fence post looking calcium oxalate monohydrate crystals, and when you zoomed out, you saw a ton of these crystals. And that is because this patient presented with ethylene glycol poisoning. Well, how did they present with ethylene glycol poisoning? They had a lactic acidosis, right? Well, it turns out that they actually didn't. One of the features of ethylene glycol poisoning is that it produces a number of toxic metabolites, one of which is glycolic acid. And glycolic acid turns out to trick a number of methods to measure lactic acid. If you use the lactase oxidase method, which is present on a number of ABGs or ISTATs, you'll ping for lactate even though it isn't there. And we frankly see this all the time in our region. In fact, I call it less the lactate gap nowadays and more, a marker of ethylene glycol poisoning when somebody shows up after drinking fluid from their garage and their lactate is elevated. So Toxic alcohols are short chain alcohols. They're all metabolized by alcohol dehydrogenase and then aldehyde dehydrogenase. The two most important ones to know for clinical practice, for boards, etc., are probably methanol and ethylene glycol. And I guess I am skipping, ethanol, the most commonly ingested toxic alcohol. But you know what? We take acetic acid, we run around the Krebs cycle so you don't actually get acidosis. And there you go. Now you know something that the Krebs cycle does that's good for clinical medicine. Anyway, methanol is metabolized to something called formic acid, which is really bad. Undoubtedly, you know that it causes blindness, right? That's the classic feature. You get an anion gap acidosis and blindness. I actually fear blindness a lot less than I do the CNS necrosis, intracranial bleeding, and brain death that comes along with methanol. Methanol poisoning worldwide is generally the cause of dozens to hundreds of deaths each year, mostly in countries that have heavy penalties for alcohol use. Ethylene glycol is a little less deadly, but it's still not great for you. It's metabolized by alcohol dehydrogenase, aldehyde dehydrogenase, and then lactate dehydrogenase because it has two hydroxy groups. And there you go, something organic chemistry is good for in clinical medicine. When you make oxalic acid makes those pretty crystals we looked at earlier look very pretty. Kidneys don't like them because those very sharp calcium oxalate crystals can lacerate renal tubules and cause acute kidney injury. And if you have a really large or late presenting ingestion, unfortunately, those crystals can form in more than just the urine and can actually form in places like the CSF or tissues, and you really don't want them there. When a patient ingests a toxic alcohol, this produces an osmol gap. Not to belabor this test, it's terrible. We do this test because we can't get real-time ethylene glycol and or methanol levels. But regardless, because it's what we have, our patient who presents after ingestion of a toxic alcohol, if they presented the ED right away, or if they drank ethanol and prevented this metabolism to a toxic alcohol, would present with a high osmol gap and a normal anion gap. And as time went on, the osmol gap would go down, the anion gap goes up. If you are taking a board exam, your patient's probably going to present here. In reality, your patient can present anywhere along the spectrum. You want them to present here, and unfortunately, the patients with the greatest clinical effects typically present here after the toxic alcohol has been metabolized to bad things. Methanol is found in windshield washing fluid, solvents, paints. We had one patient who was cleaning out a metal tube with a methanol-containing paint stripper, developed methanol toxicity from inhalation. It's almost never seen from illicit alcohol within the United States, but this is one of the more common sources worldwide. And again, methanol is metabolized to mitochondrial toxins with a particular predilection for the brain and the optic nerve. So blindness and CNS necrosis. And what you want is your patient to present before this presents, not before this develops, not here, where, for example, we have a patient who is a late presenter who has already developed putamen and midbrain damage leading to hemorrhage. This is one of the reasons why we treat methanol so aggressively and why we take even minor potential exposures seriously. Ethylene glycol is found in antifreeze primarily. It takes more of it to kill you. Generally, that's good. And it is metabolized a bit more extensively. So most of the metabolic acidosis doesn't actually come from oxalic acid. It comes from some of the intermediate metabolites. And again, the specific organ toxicity to know about is acute kidney injury. And this doesn't always mean that your patient has an elevated creatinine on presentation. In fact, when we reviewed our data, we found the opposite to be the case. The patient usually shows up without an elevated creatinine, then becomes oliguric, develops progressive acidosis, and those crystals. To treat toxic alcohol poisoning, you should use fomepizole, which is a synthetic inhibitor of alcohol dehydrogenase. It prevents all of those toxic metabolites from forming. If, however, those metabolites have already formed, dialysis may be necessary, and I'll show you some practice guidelines. What if you're not practicing at, your mega medical center, university, whatever? What if you're practicing at a smaller hospital? What if you receive a call from a smaller hospital saying, we want to transfer your patient to your large medical center because we don't have nephrologists, and by the way, we don't have fomepizole? Well, alcohol, ethanol, has been used as a synthetic inhibitor of alcohol dehydrogenase for quite some time, or a non-synthetic inhibitor, and it still works today. In fact, what we usually do is, if you're working at a critical access center, go out, get some vodka, give the patient 5 to 7 shots, depending on their body weight, try to get their ethanol level to 150, transfer them somewhere that has fomepizole. For methanol poisoning, I am going back to the XTRIP workgroup guidelines from close to a decade ago. These haven't been updated. They still hold firm. And again, this workgroup is a bunch of toxicologists, nephrologists, pharmacists, pharmacologists who all get into a room, who look at data, who debate back and forth, and then issue a systematic review. If you want to see more, I would suggest heading to their website. There's a whole bunch of different dialyzable toxins they have there. But for methanol in general, you want to consider dialysis if they have end organ toxicity, meaning coma, seizures, blindness, if they have substantial acidemia, and it's not because of the acidosis. It's because if you have substantial acidemia with methanol poisoning, you have formic acid, which does the bad things to your eyes and your brain. Or if you have a large enough number and concentration. And the reason for that is that methanol is excreted by breathing it out once you block liver metabolism. And it has a half-life of over 50 hours. So your patient is going to be in the hospital for a very long time after blocking a large methanol poisoning. You dialyze until the methanol is gone, till the acid metabolites are gone. And in general, you should use intermittent hemodialysis to dialyze these patients. For ethylene glycol poisoning, this is the new stuff. These guidelines came out roughly February. So, and if you go to the guidelines, you'll note that there's something like 400 and something references. So, in other words, it took a while because there's a lot out there for ethylene glycol. Unfortunately, none of this is randomized controlled trials, so there's still a certain amount of clinical opinion and guesswork. But in general, you should consider dialysis for ethylene glycol poisoning if you have end organ toxicity with, say, acute kidney injury or neurotoxicity. If your patient has enough of an anion gap, if you look at the paper, because the primary authors are Canadian, they use the anion gap that includes potassium. So I alter it for your standard sodium minus chloride minus bicarb here. But you don't have to dialyze ethylene glycol poisonings with, until you get to fairly high levels of ethylene glycol if there isn't acidosis or end organ damage. And the reason for that is that we can excrete ethylene glycol through working kidneys. The half-life is about 17 hours. So if you have a patient presenting with a moderate poisoning that doesn't develop severe acidemia, they can actually be treated with fomepizole and being in the hospital for a few days rather than dialysis. And in general, you dialyze till the stuff is gone. But the greatest challenge for the emergency physician, for the intensivist, for anyone who sees these patients, is differentiating non-toxic alcohol-induced anion gap acidosis from toxic alcohol-induced. I would say for about every 5 cases, let's say every 10 cases we get called about, could this be a toxic alcohol in the Maryland Poison Center? Probably about 1 or 2 are, and the rest are alcoholic ketoacidosis or something similar. And this is because of that earlier problematic issue, the osmolar gap, where the osmolar gap is a nonspecific measure of stuff floating around in the blood. There are a lot of solutes that will give you an elevated osmolar gap. The ones in black here are toxic alcohols. The ones in red here are not. And you'll notice that the ones in red greatly outnumber the ones in black. And these include things like ketone bodies, amino acids, all those weird uremic solutes, etc. So it's actually not that great of a test. And the way that we find to differentiate is to look at more than the osmolar gap. Either you have a very high osmolar gap, or you have a history of toxic alcohol use, or you have negative ethanol. And what we have found in general is that if you have either 2 out of these 3, meaning that if you have no history of toxic alcohol poisoning and an elevated ethanol level, that your odds ratio for having poisoning with toxic alcohols is 0.07. It's real low, right? Out of every 20 patients or every 14 patients, one of them will have this. So what do you do when you're not sure? Well, we will sometimes do serial basic metabolic panels for people who have, say, an anion GAPA 25, an osmol GAPA 25. Sometimes we'll use empiric fomepizole. Sometimes, almost never, we'll use empiric dialysis. Usually that's when you have a very high suspicion. Most of the time, my suspicion isn't that high unless the patient comes in and says, I drank this stuff, or has clinical features that match it exactly. And lastly, because again, nephrologist, and then I'll try to get away from the nephrology stuff mostly for the rest of the talk. If you want to dialyze a patient, you really should, for poisoning, you really should be thinking about hemodialysis for the vast majority of toxins. And the reason for that is that it's much better at clearing toxins. And yes, this even includes the hypotensive patient. It's one of my soapboxes. I'll try not to jump on the soapbox too much, but just to give you an example, this is a patient I took care of around a decade ago who had a massive ethylene glycol ingestion, received a little bit of hemodialysis and then CRRT, and did they have a good outcome? They did. Were they in the ICU for 2 or 3 days receiving CRT that they probably didn't need? They might have been. So consider talking to your nephrologist about hemodialysis. Let's go to another case. We've got a 55-year-old who ingested a large amount of verapamil in a self-harm attempt. Presented to the ED, was rapidly admitted to the ICU with bradycardia and hypotension. And before they came up to the ED, the emergency physician was doing everything they could in order to take care of this patient. These are the patients that when they come through the door, either hope you have help or just realize that the other patients are going to have to wait because you're going to be at the bedside for minimum 20 minutes pushing stuff. And on arrival to the ICU, this patient had a heart rate of 45, a blood pressure of 70 over 40. Mentation wasn't too bad, but urine output wasn't great. They had an anion gap acidosis, and lactic acidosis, and they were on high-dose pressors. So, in toxicology, we generally talk about supportive care. How do you treat most poisoning? Supportive care, right? Maybe some benzos, maybe a little bit of bicarb. Then calcium channel blocker and beta blocker poisonings come along and say, how about you treat us with 8 or 9 different vasoactive agents? Because these are extremely difficult to treat poisonings. They generally require things like this. This is for a case that's a month or 2 old from our poison center where we were involved in the care of this person who was on 3 high-dose pressors, high-dose insulin, methylene blue. They'd got a bunch of calcium pushes before that, and despite all of that, we're kind of just maintaining a decent mean arterial pressure. These are very severe poisonings and require intensive amounts of care. And the reason for that is simple, right? You take normal physiology and you mess it up. So this is a detailed depiction of a cardiac myocyte. You can admire my artistic skills. And we normally have norepinephrine bind to our beta-adrenergic receptor. This allows the adenylate cyclase to convert ATP to cyclic AMP. Cyclic AMP comes along, allows calcium into the cell. Calcium calls all of her friends up to the sarcoplasmic reticulum and said, it is time for a party, and that party involves actin, troponin, tropomyosin, and such, and they all go squeeze, right? So if this happens in the heart, you get harder squeeze and faster heart rate. If this happens in smooth muscle, you get vasoconstriction. Now we have beta blocker poisoning, preventing norepinephrine from doing its thing. You can pull out some antidotes for this, and these are antidotes that undoubtedly. One would be, well, you're blocking norepinephrine. Well, what if we just used all the norepinephrine, right? And use high-dose norepinephrine. Often these patients require quite high dose in order to overcome this blockade. Be prepared to go to the max dose. And that's because the receptor that it works on is poisoned. Alternatively, you can use glucagon to bypass your beta-adrenergic receptor and go directly to adenylate cyclase. I'm not going to talk about glucagon for the rest of this because we're focusing on calcium channel blockers, and just real quick, glucagon is about $700 a milligram. You're going to give 5 to 10 as a bolus. Then you're going to put them on that amount per hour, whatever works. And then about 4 hours later, you're going to be called by inpatient pharmacy saying we have normal glucagon. So glucagon has logistical challenges. Alternatively, a calcium channel blocker, and this is downstream of your beta blocker. This is even harder to treat because some of your most fundamental physiology is being blocked. So we pull out not only the previous high-dose norepinephrine and epinephrine, but perhaps IV calcium, or perhaps high-dose insulin, which we'll talk on. And high-dose insulin, when we say high dose, well, if you use 0.1 units per kilo per hour for DKA, we take that, we multiply it by 10, and then we might go and multiply that by 10 further. So we're using tremendous amounts of insulin. And the reason for that is that using that insulin allows glucose into the cell, allows ATP to be generated, and then allows muscle to go squeeze. If your patient is in trouble despite all this, which unfortunately isn't that rare, we pull out the red, white, and blue antidotes of lipids, methylene blue, and or hydroxycobalamin. Well, lipids are kind of like the greasy yellowish gray, but you get the picture. The patriotic antidotes. And then lastly, you might have to consider ECLS for your patients who have profound cardiogenic shock despite all of that. So going a little bit more in detail, you'll notice that we didn't stop at one antidote and says, oh, just use high-dose Norepi. Oh, just use an insulin drip. It fixes all ills. No, these patients require everything. Some of them are good early on. Some of them are good for maintenance. I would encourage you that those antidotes mentioned at the end, which we'll go to in a little bit more detail, should remain rescue, right? Don't use lipids first line. I see this. And the reason is not only are the data weaker, meaning your patient may not respond as well, they're potentially more hazardous than other antidotes. And most importantly, in the management of these patients, as you get to kind of the middle or the late phase of their resuscitation, by the time you look up, you may look at your ins and outs and say, oh gosh, we gave the patient 10 liters in the last 10 hours. And fluid overload is a very challenging thing to manage in these patients. Avoid using vasodilating inotropes. What does that mean? Don't use dobutamine, right? Use inotropes that have squeeze, especially for amlodipine poisoning, because amlodipine is not just a calcium channel blocker, it also blocks nitric oxide synthase, and you get tremendous vasodilation. So use norepinephrine and epinephrine. Use vasophenol. Use angiotensin II if you can get it, and be prepared to go to ceiling doses of these antidotes. Again, most patients with sepsis who are on 2 to 3 mics per kilo per minute of Norepi and Epi don't have good outcomes. Calcium channel blocker poisoning is one of the more likely poisonings to unfortunately present with a fatal outcome. However, our patients can survive those high doses of antidotes because, again, you're not fighting physiology that is failing because of, say, septic shock. You're fighting physiology that is failing because there is a drug blocking it. And if you can support the patient until that drug is metabolized, your patient could do better. High-dose insulin. Again, ignore the wall of text. It's for you later. The short version is you're going to be giving a lot of insulin. A unit per kilo bolus. Yes, give the 70-kilo person a 70-unit IV push of insulin. You will not kill them, I promise. Then give them 70 an hour, maybe 140 an hour. You will still not kill them unless you fluid overload them. Use the most concentrated insulin that you can. Consider talking with your P&T committee. In Maryland, both University of Maryland and Hopkins have concentrated insulin, and I don't believe other hospitals do. So if you work at another hospital in Maryland or you work at another hospital elsewhere, ask if you have concentrated insulin. And if you don't, think about maybe getting it. Contact me. We'll be happy to help. Also think about using concentrated dextrose. Don't use D10. Use D20. Use D70. Your hospital pharmacy has this to make TPN. See if they will give it to you. It's like maple syrup IV, only without the maple. Your patients are almost certainly going to be hypokalemic, although they're probably not going to be hypoglycemic if you give them enough sugar. And again, watch that volume overload. Lipids work via this hypothesis that has been mostly experimentally proven that you give a patient a bolus of fat and you're fat-soluble drug will diffuse into said fat. It also serves as an inotrope on its own. Heart likes free fatty acid and will use it even in the absence of poisoning. Typically, you should use it for refractory shock. Most of the data for the use of lipids is in local anesthetic toxicity. Most of the calcium channel blocker data is neutral. They are reasonably widely used. I would just encourage you not to use them as first line. In terms of the problems from lipids, why don't you use them as first line? Because pressors don't usually cause pancreatitis and they don't usually cause ARDS, but lipids can. So be cautious with them. Alternatively, you can use your nitric oxide scavengers. These have been more increasingly used in the past 5 years nationwide. The data aren't great. It's toxicology, right? We have the case series, not the large randomized controlled trial. But the idea behind both methylene blue and hydroxycobalamin is that they work as vasoconstrictors. And we're talking case report level data. We're not talking randomized controlled trials, but we've used them in a variety of poisonings and they do seem to help, although they should be reserved after your conventional therapies have been tried. Hydroxycobalamin, your cyanide antidote, is most frequently used in the US for smoke inhalation, but nowadays we see it a lot more for vasoplegia after cardiac surgery. It scavenges nitric oxide. Same deal, right? Your vasodilator. So if you have a nice vasoconstrictive response, not a bad thing. Once you give it, note that your labs will not be reliable for 12 to 24 hours. You can't get creatinine, you can't get AST, and you can't carry out intermittent hemodialysis, which is usually not a problem, frankly, because your patient is really hypotensive and generally requires CRRT. And if you do CRRT, like I did for this patient, and you can see this is the color of the urine, and since there isn't a whole lot of urine there, we did CRRT, and that's the color of the effluent that came out of the machine. This turns everything red. Lastly, I am sometimes asked, because the whole tox nephrology thing, hey, can we dialyze out calcium channel blockers? What about apheresis? What about albumin dialysis? And the short version is, no, these are very lipophilic drugs. They sit primarily in the tissue. Extracorporeal removal doesn't work. Do all the supportive stuff we just talked about, not dialyze them out. So let's move to our last case. This is a 20-year-old we took care of within the past few months, who presented with a massive ingestion of extended-release acetaminophen, the arthritis formulation, had a high initial acetaminophen level, was treated with N-acetylcysteine. Their acetaminophen level didn't come down more correctly. Then they got sicker, and their acetaminophen level spiked dramatically. And this is an example of a massive acetaminophen poisoning, not your average. So how does acetaminophen cause toxicity? Well, most of it gets metabolized to non-toxic metabolites. So by this time, my voice is grating on, you're like, a headache, fine, I'll take some Tylenol, which you can do without fear because it all gets metabolized to non-toxic metabolites. And the 3 to 5% that go through CYP2E1, the scary P450, make N-acetyl-P-quinonamine, your highly reactive substance that can cause liver injury. If you have a patient who regularly uses alcohol, CYP2E1 is upregulated. So alcohol use is a risk factor for acetaminophen poisoning. It's not just because of a bad liver. Thankfully, if you're taking it therapeutically, you have enough glutathione to get rid of this bad metabolite. Unfortunately, if your patient has malnutrition, they're less likely to have as much, and chronic acetaminophen poisoning becomes a greater risk. And alternatively, if you don't metabolize NAPQ via glutathione, it hurts your liver, it makes reactive oxygen species, adducts to DNA, does all the bad things, and that's when you need to consider treating your patient with N-acetylcysteine. So, thankfully, the vast majority of acetaminophen poisonings are treated effectively with NAC. It is one of our most effective and most proven antidotes. If you have a patient who has the normal natural course of acetaminophen poisoning, without NAC, they typically present with initial nausea, vomiting, have symptom resolution but massive LFT elevation, develop liver failure, possibly acute kidney injury because the kidneys also have CYP2E1, and then develop, complications of that. At this point, the patient either recovers or has a liver transplant, or passes away, hopefully the former. We decide whether to use NAC based on the Rumac methanomogram that undoubtedly you're familiar with, that takes your acetaminophen level and the time of presentation and says this person is at moderate risk of liver injury. Hey, let's give NAC, or we think this patient's at low risk. We don't need to treat them with NAC. Unfortunately, this wasn't developed for the massive poisoning, but for your average patient, when do you use it? Well, you use it for any presentation with liver injury, or perhaps certain non-acetaminophen-induced liver injury, or you use the nomogram, and you use it until the acetaminophen is gone and the liver either never got hurt or is getting better from its hurt. But what do you do for the massive poisoning, where we see higher acetaminophen levels on presentation having a much greater risk of hepatotoxicity? And to top it off, our antidotes may not work as well because they weren't designed for I can get 500 milligrams of acetaminophen with 500 pills from your large big box store. So what do we do? Well, here are 3 approaches which have really reached prominence within the last several years: high-dose NAC, fomepizole, and hemodialysis. So the principle besides high-dose NAC is that if you have a massive overdose, you don't have enough NAC to neutralize toxic metabolites. So more NAC, more better. What we usually do is take the FDA protocol and make a tweak to increase the terminal dose, 2 or 3 or 4 times the dose. What is the evidence? I mean, come on, it's toxicology, right? And I said the last several years, they got case series, that's it. This is an example of high-dose NAC protocols where, depending on what your starting acetaminophen level is, and this is a log scale, we'll use higher doses of the terminal rate of your N-acetylcysteine in order to neutralize your more NAC, or your more acetaminophen. The idea behind fomepizole is that if CYP2E1 is a problem, we actually have a drug that inhibits it. It's that whole alcohol dehydrogenase inhibitor. It also inhibits your P450s. So we give fomepizole to prevent injury. And we have extensive evidence. No, we don't. We have like a couple case series. Actually, case reports, not even series. And you can see, I mean, even the basic science is only 4 years old, where rats who were given acetaminophen alone developed acute liver injury, massive transaminitis. Rats who were given acetaminophen plus fomepizole didn't develop this injury. So, in fact, it beat out NAC in the rat trial. So it sounds pretty good. There is a forthcoming clinical trial. It'll be done in several years, and then it'll take another couple to digest, and then it'll be out there, and then we'll debate it. And, so maybe this will be FDA approved if it works in a decade. And until the meantime, it's a little bit of the Wild West, whether or not you use it. Our Poison Center does not have it in official guidelines. There are forthcoming national guidelines for NAC use, or for acetaminophen poisoning, that do not include it because the data aren't there. But we'll use it for scattered cases. And lastly, hemodialysis. If acetaminophen is a problem, it's dialyzable. If you present with a massive amount of acetaminophen, you can dialyze it out. This extra paper has been out for probably 8+ years, and the evidence still isn't great. However, for your presentation where your patient presents with levels above 600 and mitochondrial dysfunction, it's worth a consideration because you can actually develop liver necrosis to the point where you actually see mitochondrial dysfunction, shock, lactic acidosis, encephalopathy before your LFTs even bump. So we would consider using hemodialysis for acetaminophen poisoning if you have the almost mythical level of over 900, or practically what many of us do are for these sicker patients with metabolic acidosis, elevated lactate. We think it's due to acetaminophen. The levels above 600 or 700, we'll often consider it. That is outside of their guidelines. But regardless, you usually don't have to dialyze. And if you do, increase your NAC rate because you'll dialyze out the NAC too. So lastly, can we change the fate of your late presenting patient? There are trials on calmangafodipir, which is really hard to say, which is another reactive oxygen species stimulator. Maryland and a few other hospitals across the nation have MARS, your albumin dialysis, where I may not like it for removal of toxin, but it actually could, potentially save your patient a transplant in the odd patient, or act as a bridge to transplant in the critically ill patient. So consider that as well. Otherwise, just remember, sola dosis facit venenum. Everything is a poison. Thanks.